Hello, my name is Akanksha Sharma, and I'm a neuro-oncologist and a palliative medicine specialist at Santa Monica at the Pacific Neuroscience Institute. I'm honored to be here at the first International Neuropalliative Care Society meeting, and I'm looking forward to an excellent conference. Thank you to everyone who has put in so much work for this meeting. I'm honored to be an abstract presenter, and I'm excited to tell you a little bit about the work that I've done while I was a fellow at the Mayo Clinic in Arizona. This work was done under the guidance of Dr. Alyx Porter, who was my co-investigator. This was published in the Journal of Neuro-Oncology earlier this year, and more details can be found in that article. This project stemmed from a desire to learn more about how patients with glioblastoma and high-grade glioma understand their prognosis. We were also curious in understanding how the experience of the caregivers differed from the patients. This trial is part of a larger trial that we conducted that was evaluating a tool on a smart device to assess the primary concerns for patients and their caregivers. Each visit, patients used a tablet to identify their primary domain of concern and answer some follow-up questions. The survey took barely 1 minute. To this single-center trial, we added a question assessing prognosis. This was a prospective, single-center, cluster randomized pilot phase 1 study. We included 16 patients and 16 caregivers. Patients and caregivers visited their neuro-oncologist monthly, which is standard practice in a neuro-oncology clinic. As I discussed, they filled out a survey about their concerns, and at the end of the survey, they were asked a question about their expected prognosis. If asked how much time you have to live, which of the following closely matches your belief? For the caregivers, the question was, if asked how much time your loved one has to live, which of the following closely matches your beliefs? As per a recommendation from the field of palliative medicine, we use ranges instead of specific times, as described here, and we also made sure that all providers discuss prognosis at least once during the diagnosis phase. All 16 patients and their caregivers were given this question. All except one dyad answered the question. The couple that did not answer the question chose "I do not wish to answer," and they were transitioning to hospice that day. What we learned was very interesting. Over time, there was significant variance in patients' own opinion about their prognosis. The blue line here signifies patients, the orange line is the caregivers, and the gray line is the neuro-oncologist. We can see that the most significant variance from visit to visit was with patients. Their opinion on their own prognosis seemed to go from dismal, which is right here, to truly optimistic, and then somewhere in the middle. This fluctuated from month to month. The caregiver's opinion also fluctuated, but to a lesser degree, and the neuro-oncologist had less variance overall. Here in this figure, I give you examples of patients versus caregivers to show you the significant dissonance. So for example, these are 3 patients, patient 1 in blue, patient 3 in orange, and patient 5 in gray, and this is their respective caregiver. You can see the fluctuations from month to month for patient 5, and then for their caregiver, it really does not correlate. The same is true for patient 3 and patient 1. When we looked at the overall optimism, we found that caregivers tended to be the least optimistic, which is shown here in this figure. We compared the relative optimism with how often patients selected weeks versus weeks to months versus years. And as you can see here, the weeks is the blue, and there's very little selection here, and even less with caregivers. Of course, neuro-oncologists, palliative care clinicians were more optimistic and never chose weeks. And so, in fact, neuro-oncologists were as optimistic as patients, if not more optimistic. And caregivers were more likely to choose weeks to months, which is right in the middle, but more on the pessimistic aspect. We found that inquiring about a patient's own prognostic prediction on a routine basis was feasible and could be helpful in understanding how they understand their own prognosis. There was considerable fluctuance in prognostic understanding, and it also varied greatly between patients and caregivers. This is important because this suggests that Prognostic understanding is not a static phenomena, but evolves and fluctuates over the course of the illness, and therefore we should have evolving dialogues between clinicians and their patients, including their families, and there might be times where caregivers might have different needs and questions than patients. Dissonance between a patient and a family can be a source of distress and impact decisions at end of life. Often patients with glioma still make their own decisions later in the course of their illness when they may not have a good understanding of their prognosis or may have cognitive impairment. This suggests the data we found today is very similar to what is seen in other oncological diagnoses, that caregivers may know more and may have a more accurate perception of how their loved one is doing, and it should be questioned if we ask our caregivers for their input enough and if we include them in decision making enough. So this is early work that I hope to expand upon in the brain tumor population. Thank you so much for your attention today.